I'm back, just when you thought I'd made my last podcast. Here I am again, bringing you medicine and music, and this one, if you don't recognize it, is the theme from Rawhide, sung by Blue Brothers.
Though the streams are swollen, keep them doggies rolling, rawhide. Rain and wind and weather, hell bent for leather, wishing my gal was by my side.
And welcome back to Med School Radio. This is Simon coming to you from Central Tokyo. And this time we're going to be talking about primary-nephrotic syndrome, thanks to MedBullets. And this says a great summary here, plus some MCQs. So let's get right to it. Let's start with a question stem. I'm looking at an image here which you can't see. But it says that a 3-year-old boy presents with puffy eyes to the ER. His physician had treated him for allergies, but the symptoms did not improve. On physical exam, the patient is noted to have lower extremity edema and has serum albumin of 2.5 grams per deciliter and 4 plus proteinuria on urinalysis. Electron microscopy is shown on the right, which you cannot see. Introduction. This can be broken down into two types: primary nephrotic syndrome, which refers to disease limited to the kidney, and the subtypes include minimal change disease, focal segmental glomerulosclerosis, diffuse membranous glomerulopathy, and membranoproliferative glomerulonephritis. And then there is secondary nephrotic syndrome, and this is a multi-system disease and associated conditions. For example, spontaneous peritonitis, in which there is an increased risk due to Streptococcus pneumoniae infection, and thromboembolism, where you would see a DVT and a PE. And in this case, you would be in a hypercoagulable state with a risk of DVT, which is due to loss of antithrombin 3 in the urine. So that seems like it could be a good question. How about the presentation? Symptoms. There would be periorbital swelling. On physical exam, hypertension, generalized edema, called anasarca, and caused by loss of albumin or decreased oncotic pressure. In the evaluation, the labs, you would see hypoalbuminemia, a serum albumin of less than 3 grams per deciliter, and proteinuria of 3.5 grams per day, at least 3.5 grams per day. So when you look at the word nephrotic syndrome, it has an O in it, and so you should remember that this is a loss of protein. And there would be a high protein urine, which would be frothy. Hyperlipidemia with lipiduria would also be seen, and this would show low albumin. So low albumin stimulates the liver to produce cholesterol to correct the decrease in plasma oncotic pressure. In urinalysis, you'd see fatty casts, Maltese crosses resulting from hyperlipidemia, which is a key finding in nephrotic syndrome. On microscopy, there would be light and electron microscopy, both critical to establishing the diagnosis. And in a second, I'm going to tell you about some of the differences you would see on light microscopy versus the electron microscopy. And remember that the immunofluorescence is also critical to establish the diagnosis. So quickly going through this table, looking at minimal change disease, you wouldn't see anything on immunofluorescence, nothing in that pattern, and no location of immune complexes and no complement. For focal segmental glomerulosclerosis, you're going to see a negative immunofluorescence pattern also, and no immune complex deposition and no complement activation. For diffuse membranous glomerulopathy, you're going to see a granular immunofluorescent pattern, and you will see subepithelial immunocomplex deposition, not endothelial, epithelial for diffuse membranous glomerulopathy, and there's no complement type activation. But for membranoproliferative glomerulonephritis, you will see granular, as you did for diffuse membranous glomerulopathy, and you would see subendothelial, not epithelial this time, it's subendothelial location that you would see immunocomplex deposition, and it would be subendothelial. And this time you are going to see complement type activation. You will see classical and alternative. We're going to talk about that below. So let's take a short break here before we talk in detail about these diseases.
I have solved my problem and I'm ready to pick.
Well, I am too. I want.
Like the days of old when me and you and Larry McNeely and Bob, you know.
Remember
Wasn't that great?
That sure was.
12 years ago. Where'd you
It
go?
was 12 years ago. Well, you showed me a lick back then. It went.
And I want to hear that. Do we want to hear Southern Nights, people? Hey! Hand it off, Bill. Yes.
I want to thank Jerry Reed for this lick, because this song wouldn't have made it without it. Southern nights, have you ever felt a southern night? Yeah. You're just free as a breeze, and not to mention the trees, are whistling tunes that you know and love so. Southern night, well, they're just as good even when close your eyes, yeah. And you know what, Reed? I'll apologize, yes I will, to anyone who can truly say they have found a better way, yeah.
I really like that song. It's Glenn Campbell and Jerry Reed both passed away. It was a really great song. Okay, let's continue with the definitions, starting with minimal change disease, also known as lipoid nephrosis. Introduction. This is the most common cause of nephrotic syndrome in children. Remember that. And I think that should be quite easy to remember. It results from a loss of polyanions, negative charge, in the glomerular basement membrane, selective loss of albumin, but not globulins, and it is associated with allergic diseases. It may be triggered by a recent infection or an immune stimulus, for example, a vaccination, and treating the allergy often improves the nephrotic syndrome. It presents with periorbital edema in a normotensive child following an upper respiratory infection or immunization. For the evaluation, serology shows hyperlipidemia and hypoalbuminemia. Light microscopy findings show completely normal glomeruli, hence the name minimal change, and urinalysis shows Maltese crosses. Electron microscopy findings show effacement of podocytes. And to treat this, you would use prednisone. The disease is very responsive and has an excellent prognosis. And regarding the prognosis, prevention, and complications for infection, there is you're at risk for encapsulated organisms, for example, especially S. pneumoniae. Okay, so let's move on to focal segmental glomerulosclerosis. This is the most common cause of nephrotic syndrome in adults. It is clinically similar to minimal change, but occurs in adults with refractory hypertension. It is different in that the protein loss is nonspecific, unlike MCD, which is selective for albumin. It is usually idiopathic and can be associated with IV drug use, for example, heroin, HIV, diabetes mellitus, and sickle cell anemia. It presents typically or commonly you might see a young black hypertensive male, so look for that in the question stem. Evaluation. Light microscopy will demonstrate segmental sclerosis and hyalinosis. Electron microscopy will demonstrate foot process effacement. And remember, the immunofluorescence is negative. Treat with prednisone and or cyclophosphamide. The prognosis, prevention, and complications is very poor due to refractory disease. So that's FSGS. Moving on to diffuse membranous glomerulopathy. First introduction. The causes include infection, for example, hepatitis B or hepatitis C virus, syphilis, and malaria. Drugs can cause this, such as captopril, gold, and penicillamine. And occult malignancy and SLE, which is found in 10% of patients. Presentation presents with general signs and symptoms of nephrotic syndrome. Evaluation. Light microscopy shows diffuse thickening of capillaries and the GBM. Electron microscopy shows subepithelial deposits which show a spike and dome appearance. So remember, spike and dome for diffuse membranous glomerulopathy. And you would see diffuse thickening of the capillaries and the GBM, which makes sense coming from the name. Treat with prednisone and or both cyclophosphamide plus or minus. Prognosis, prevention, and complications. Slowly progressive disorder with decreasing response to steroids. Okay, so that was diffuse membranous glomerulopathy. How about membranoproliferative glomerulonephritis? Yeah, I often get these confused. So there are two forms of membranoproliferative glomerulonephritis. The first one, type 1, is slowly proliferative. And there's the association here between hepatitis B and C. Hepatitis B virus is more than the hepatitis C virus. Type 2 is more aggressive. It results from a C3 nephritic factor, C3NEF, which is an autoantibody against C3 convertase, which leads to continuous activation of C3. Presentation is similar to general nephrotic syndrome. Evaluation. Type 1. The EM shows tram track appearance of the GBM due to splitting by mesangial growth. Type 2. Serology shows a decrease in serum C3 levels. Treatment. Prednisone plus or minus plasmapheresis. Prognosis, prevention, and complications. Very poor prognosis with slow progression to CRF. So let's take another little break there.
He shoveled coal to make a poor man's dollar. My daddy worked all night in the Van Leer coal mine, all day long in a field of hoeing corn. Mommy rocked the babies at night and read the Bible by the coal oil light, and everything would start all over come break of morn. Daddy loved and raised their kids on a we'd all get a brand new pack. From a miller to catalog, money made from selling a hog. Daddy always managed to get the money somewhere. Yeah, I'm proud to be a coal miner's daughter. I remember well the well where I drew water. The work we done was hard, and I would sleep 'cause we were taught. I never thought of ever leaving Butcher Holler. Well, a lot of things have changed since the way back then, and it's so good to be back home again. Not much left but the floors, nothing lives here anymore, except the memories of the coal miner's daughter.
Okay, let's continue on with the questions. We have some great questions here from Med Bullets. Let's take a look at them. Okay, question number 1. A 5-year-old female presents to your office with periorbital edema and proteinuria. Her mother reports that she just got over a cold last week. On examination, you note a pulse rate of 70 per minute and a blood pressure of 95/53. Which protein or proteins would likely be found in large amounts in the patient's urine? So the buzzwords here: 5-year-old, periorbital edema, proteinuria, just got over a cold. So choice 1, IgA, choice 1 was IgG, 2 is IgA, 3 albumin, 4 albumin and IgG, 5 albumin, IgG, and IgA. And the answer is 3, albumin. The patient's presentation is consistent with minimal change disease, the most common nephrotic syndrome in children. In MCD, T-cell cytokines cause the glomerular basement membrane to lose negative charge, resulting in selective proteinuria in which albumin, but not immunoglobulins, is lost. Patients with MCD are typically normotensive and have peripheral or periorbital edema, proteinuria, hypoalbuminemia, anemia, and hyperlipidemia. Patients may present following an upper respiratory infection or immunization. The disease is more common in girls and peaks at age 2 to 3. On light microscopy, the glomeruli appear normal, hence the name minimal change. However, effacement of the foot processes is seen on electron microscopy. That was a good question. Okay, next one, number 2. An 11-year-old boy presents to your office with pitting edema and proteinuria exceeding 3.5 grams in 24 hours. You suspect that this patient has experienced a loss of polyanions in his glomerular basement membrane. Which of the following findings would confirm your diagnosis? 1. WC casts in the urine. 2. RBC casts in the urine. 3. Selective albuminuria. 4. Negatively birefringent crystals in the urine. 5. Bence-Jones proteinuria. The answer is 3. Selective albuminuria. The patient described in the question stem has minimal change disease, the most common cause of the nephrotic syndrome in children. Remember that MCD results in selective albuminuria. Like other conditions causing nephrotic syndrome, MCD presents with generalized edema and proteinuria. So remember that it exceeds 3.5 grams a day, and that MCD is unique in that it causes a selective albuminuria. Albumin, which has a negative charge, is normally held within the glomerular capillaries by an anionic charge within the glomerular basement membrane, provided by the polyanion sialic acid. Loss of this anion change results in a loss of albumin in the urine. More broadly, proteinuria in children has a wide differential diagnosis. Anyway, let's skip the research here. I want to talk about why some of the other answers were wrong. For example, number 4, negatively birefringent crystals are associated with gout. And Bence-Jones proteinuria is associated with multiple myeloma. That's probably going to come up with in a question. White blood cell casts are associated with acute pyelonephritis or acute tubulointerstitial nephritis, and red blood cell casts are associated with nephritic syndrome of glomerulonephritis. Okay, next question. How are we doing on time here? We're okay. Number 3, a 52-year-old African-American male, there you go, has the buzzword, with a history of HIV and obesity presents to his primary care physician because of recent changes in his health. He states that while he has been compliant on his HIV medication, he has noticed recent fatigue and increased swelling in his face and legs. A routine urinalysis demonstrates proteinuria and fatty casts. Based on these findings, the physician decided to proceed with a kidney biopsy. Which of the following figures most likely represents the findings in the patient's kidney biopsy? You can't see these. You have to go to medbullets.com to see them, but I like the response. I just want to read it. The patient presents with nephrotic syndrome, most likely focal segmental glomerulosclerosis. Figure B, which is associated with African American race, obesity, heroin use, and HIV. FSGS is the most common cause of nephrotic syndrome in adults, behind membranous glomerulonephritis. It typically presents with the findings typical of nephrotic syndrome: edema, fatigue, hypoalbuminemia, proteinuria, and hyperlipidemia. It is commonly associated with African American patients, obesity, heroin use, and HIV. On kidney biopsy, focal areas of segmental sclerosis are observed, as shown in Figure B. Prognosis tends to be poor due to refractory disease. All right, next question. Number 4. A 7-year-old male suffers from generalized edema. Urine protein excretion is 5.2 grams over 24 hours, and serum analysis reveals hyperlipidemia. The patient responds to treatment with prednisone, and 8 weeks later his urine does not contain measurable protein. If a kidney biopsy had been performed while the patient's condition was pathologic, which of the following would you expect to find upon glomerular electron microscopy? 1. Effacement of podocyte foot processes. Remember, this is asking about the electron microscope. 2. Subepithelial spike and dome deposits. Which was that in, do you remember? 3. Subepithelial humps. 4. Thin glomerular basement membrane. Or 5. Endothelial thickening. And the result here is 1. Effacement of podocyte foot processes. The clinical scenario describes a child suffering from minimal change disease. In minimal change disease, effacement of podocyte foot processes can be seen upon electron microscopy. Edema, hyperlipidemia, and urine protein excretion of greater than 3.5 grams over 24 hours are cardinal features of nephrotic syndrome. Minimal change disease, lipoid nephrosis, is the most common cause of nephrotic syndrome in children aged 1 to 7 and is often responsive to steroid treatment. Focal segmental glomerulosclerosis is also common in children and produces nephrotic syndrome. However, the disease is less consistently responsive to steroid treatment than minimal change disease and does not produce characteristic findings upon electron microscopy. So there's your answer there. So let's look at the other answers here. About number 2, subepithelial spike and dome deposits are characteristic of membranous glomerulonephritis. Subepithelial humps are characteristic of acute proliferative glomerulonephritis. Better write that one down. Just writing down my notes for the final here. And a thin glomerular basement membrane is characteristic of Alport syndrome. And number 5, subendothelial thickening is characteristic of membranoproliferative glomerulonephritis. Okay, question number 5, 2 more to go. A 57-year-old female visits her primary care physician with 2+ pitting edema in her legs. She takes no medications and does not use alcohol, tobacco, or illicit drugs. 4.5 grams of protein are collected during 24-hour urine excretion. A kidney biopsy is obtained. Examination with light microscopy shows diffuse thickening of the glomerular basement membrane. Electron microscopy shows subepithelial spike and dome deposits. Which of the following is the most likely diagnosis? 1. Minimal change disease. 2. Post-infectious glomerulonephritis. Write that down. Another good one to study. And focal segmental glomerulonephritis, number 3. And 4, rapidly progressive glomerulonephritis. 5, membranous glomerulopathy. So which one is it? The answer is number 5, membranous glomerulopathy. The patient's symptoms and urine studies are indicative of nephrotic syndrome. Diffuse thickening of the glomerular basement membrane and subepithelial spike and dome deposits are features of membranous glomerulopathy. Features of nephrotic syndrome include peripheral edema and proteinuria above 3.5 grams per day. And membranous glomerulopathy is the most common cause of nephrotic syndrome in adults, whereas minimal change disease is the most common cause of nephrotic syndrome in children. So that answer was number 5. So answer number 2, post-infectious glomerulonephritis and rapidly progressive glomerulonephritis each result in a glomerulonephritis clinical scenario characterized by hypertension and red blood cell casts in the urine. These are not necessarily associated with nephrotic range proteinuria. Number 3, focal segmental glomerulosclerosis is characterized by negative immunofluorescence and non-albumin specific proteinuria. Okay, let's move to the next question. Oh, just checking to see what song's playing. Let's turn that up for a second.
I'ma run up in your house, put it in your mouth. I might be new to the game, but it's a damn shame what a brother about to do to the game. I got Mark Ron backing me up. I'm already on a song with Nate Dogg. That's why you wanna hate, dog? Here's a warning: when Mark bring the horns in, say the wrong thing and you won't see the morning. You won't get dealt with, man. Yo, Nate, man, let's ride on these bitches. Come on.
This one, Justin Bieber, Fast Car, Tracy Chapman cover in the Live Lounge.
I gotta take it to anywhere. Maybe we can make a deal. Maybe together we can get somewhere. Any place is better.
Okay, let's go to the last question now. Question number 6. A 6-year-old girl presents to your clinic 2 weeks after receiving a routine immunization in preparation for a trip overseas. Periorbital edema is present on exam and 24-hour urine collection shows excretion of 4.3 grams of protein per day. Which pathological change would likely be seen on microscopy? 1. Linear IgG deposition on light microscopy. 2. IgA immune complexes in the mesangium on electron microscopy. 3. Tram track appearance on light microscopy. 4. Subepithelial deposits with spike and dome appearance on electron microscopy. 5. Podocyte effacement on electron microscopy. So let's look at the question stem. So 6-year-old girl, periorbital edema, 4.3 grams of protein per day. So what are we going to see here? What do you think it is? I'm going to say number 5. Yes, okay, number 5. The clinical scenario describes a girl who is suffering from nephrotic syndrome secondary to minimal change disease. The pathognomonic histologic finding is podocyte effacement on electron microscopy. So we talked about this before. Remember that MCD is the most common cause of nephrotic syndrome in children. While the pathogenesis of minimal change disease is not fully understood, the functional deficit stems from loss of negative charge on the glomerular basement membrane that usually repels negative serum proteins such as albumin and transferrin. Because the filtration of only certain proteins is increased, MCD is considered a selective glomerular nephropathy. Increased excretion of protein in the urine results in decreased plasma oncotic pressure and peripheral edema happens. Just want to look at some of the wrong answers. The answer there was 5. Number 1, linear IgG deposition is characteristic of Goodpasture syndrome. And IgG1C deposition is characteristic of Berger's disease, which is a nephritic syndrome. And 3, tram track appearance on light microscope is characteristic of membranoproliferative glomerulonephritis. And subepithelial deposits with a spike and dome appearance on EM is characteristic of diffuse membranous glomerulopathy, the most common cause of adult nephrotic syndrome. So some great things there. I think this was a good summary. Go check out medbullets.com. And today we were looking at primary nephrotic syndrome. So let's listen to one more song. Oh, that was Led Zeppelin, Bonheur. That was a good one. Thanks very much.